Okay, so this is just a mini lecture on cardiac output. This correlates to chapter 18, section 7. So 18.7. I'm just going to touch on a couple of the more complicated things and leave the rest for you to read. Okay, so starting with what is cardiac output? This is the amount of blood pumped out by each ventricle in 1 minute. How do we find out how much blood is pumped out by each ventricle in 1 minute? We have to find out how many beats there are per minute, so that's our heart rate, and how much volume each ventricle is pumping out with each beat. That's our stroke volume. Our average heart rate is about 75 beats per minute, and our average stroke volume for each ventricle is about 70 milliliters of blood that it's going to pump out with each beat. If we did the math, we would see that this is about 5,250 milliliters. If we converted milliliters to liters, we'd see our cardiac output is 5.2 liters of blood per minute that our heart is pumping. This is pretty significant because our entire adult blood volume is 5 liters. So that means every minute we are passing our entire blood supply through our heart. Another thing I want you to recognize when we look at the formula for cardiac output is that if we increase our heart rate and or our stroke volume, that's going to directly increase our cardiac output. If we decrease our heart rate and or our stroke volume, that's going to automatically decrease our cardiac output. Both our heart rate and our stroke volume have other variables that affect whether or not they're increased or decreased, which we're going to talk about, and then you have to correlate what those variables do to each one and how that affects cardiac output. The only thing on this slide I really want to mention is what cardiac reserve is, and that's the difference between your resting and maximal cardiac output. So at rest, what is our heart rate times our stroke volume, and then if we're running a sprint, what is our maximal cardiac output? So the difference between those two is our cardiac reserve. Our cardiac reserve is typically higher and our cardiac output in athletes, and then non-athletic people typically have a lower cardiac output and a lower cardiac reserve. Here's a video if you want to click the link and watch it. Okay, so again, when we talk about cardiac output, we said that that is heart rate times stroke volume. What we're going to focus on is factors that affect stroke volume, and if they increase stroke volume, they automatically increase cardiac output. If they decrease our stroke volume, they're going to decrease our cardiac output. So how do we figure out our stroke volume, or the amount of blood that's pumped out of each ventricle every minute? Well, there's a formula, and our stroke volume is our end diastolic volume minus our end systolic volume. And if you remember, our end diastolic volume is the maximum amount of blood that we have collected during our ventricle diastole or during relaxation, so the max amount of blood in our ventricles. And our end systolic volume is the amount of blood that's remaining in the ventricle after we contract it. So the difference between our max amount and what's left over after contraction is our stroke volume, how much we actually pumped out. So how can we affect our end diastolic volume? Well, it's affected by the length of our ventricle diastole, so how long our ventricles are relaxing and filling, as well as our venous pressure. And systolic volume is going to be affected by our arterial blood pressure and how much force we use when we contract our ventricles. Normally, our stroke volume is about 70 milliliters per beat, and that's what we used up here to find our blood volume. Okay, so stroke volume is what we're focusing on now. What affects the stroke volume? We have preload, contractility, and afterload, which we'll talk about all three in a second. But just as an overview, if we increase our preload, that's also going to increase our stroke volume. If we increase our contractility, that's going to increase our stroke volume. But if we if we increase our afterload, that's actually going to cause a decrease in our stroke volume. And you're about to learn why. So first we're going to talk about preload. So what is preload? Preload is the amount at which our muscle cells can stretch. So we're talking about how much can our ventricles walls stretch is going to determine how much in diastolic volume we have. How much are they filled before we contract them? So preload really only affects in diastolic volume. How much can we fill it during relaxation? How do we know how much volume we can have in our blood, or the end diastolic volume? That's going to come down here. So that has to do with venous return. If we increase our venous return, or the amount blood coming back to our heart, that's going to increase how much we fill our ventricles during diastole, which is going to increase our end diastolic volume, the max amount of blood in our ventricles at the end of diastole before they contract. If we increase our diastolic volume, we're going to increase our stroke volume, because remember, stroke volume is equal to N diastolic volume minus N systolic volume. If we increase this number, we're automatically going to increase our stroke volume. This relationship between end diastolic volume and stroke volume is called the Frank-Starling law of the heart. Anytime we increase our stroke volume, if we looked at that formula, cardiac output is equal to heart rate times stroke volume, we also increase our cardiac output. So increasing our venous return, or how much blood we're sending to our heart, is going to increase our end diastolic volume, or the amount of blood that's going to be in our ventricles before they contract, which is ultimately going to increase our stroke volume, the amount of blood pumped out by each ventricle, which is ultimately going to increase our cardiac output. If we decrease our venous return, so say we have an injury that causes us to have some blood loss. So if we have blood loss, we're going to decrease our venous return, which is going to cause us not to fill our ventricles as much during relaxation. So it's going to lower our end diastolic volume, which is ultimately going to lower our stroke volume and our cardiac output. The other thing that can affect stroke volume is contractility. And I told you earlier that an increased contractility is going to increase stroke volume. So what is contractility? That is the strength of your contraction, basically. So we talked about preload. That was how much can we stretch our ventricles. Now we're talking about contractility. How much strength does our ventricle apply when it's contracted? So we're not really talking about how much we can fill during relaxation when we talk about contractility, so it's not going to affect our end diastolic volume. However, it is going to affect our end systolic volume. So the stronger we can contract our ventricles, the less blood that's going to be left in our ventricles after contraction. So we're going to have a lower end systolic volume if we have increased contractility. If we have something that, say, weakens our heart muscles and it's going to lower our contractility, it's not going to be able to push as much blood out of our ventricles with each pump or contraction, which means there's going to be more blood left in our ventricles at the end of contraction, which means we're going to have a higher end systolic volume. So what are some things that can increase contractility? Epinephrine is a huge one. We talked about our two-chain neuron system and AMP1. What does epinephrine ultimately do? It's going to increase the amount of calcium entering our cells, which allows for more cross-bridge cycling, because it's going to bind troponin and cause tropomyosin to move off so that our myosin heads can bind to the G-actin subunits. So things that can increase contractility, one of which is epinephrine released by our sympathetic nervous system. They're called, in general, positive inotropic agents. Things other than epinephrine that can do this are thyroxine, glucagon, digitalis, and a lot of extracellular calcium. Because remember, when we're talking about cardiac muscle, it only gets a small amount of its calcium source from the sarcoplasmic reticulum. When we talked about muscle cells, they got all of their calcium from the sarcoplasmic reticulum. Cardiac cells rely on the majority of their calcium to come from the extracellular fluid. So the more calcium we have outside of the cell, the more likely we're going to have more calcium influx, leading to more cross-bridge cycling. We can also have some agents that are going to decrease contractility, and these are called negative inotropic reagents. So things that do that are things like being in a really acidic environment, so acidosis. If we have a lot of extracellular potassium, that's going to inhibit contraction. Or if we block the channels that are allowing calcium to come in. So if we administer a calcium channel blocker. So here's just a picture of how norepinephrine or epinephrine work. So again, this is released by your postganglionic neuron in your sympathetic nervous system. Norepinephrine binds your beta adrenergic receptor. Adrenergic receptors, if you remember, are the ones that bind epinephrine, adrenaline, noradrenaline, or norepinephrine. If we're talking about the heart, this adrenergic receptor in the heart is specifically called your beta 1. And I think you had to know that for AMP1. So norepinephrine binds to the beta adrenergic receptor in your heart. That's this thing right here. What it's going to do is it's going to cause GTP, which is another form of energy that's like ATP, but with a guanine instead of an adenine. And cause it to shift this G protein right here. This is a G protein, all the way over to another transmembrane protein called adenylate cyclase. Adenylate cyclase is going to cause ATP, which is the energy source that you're used to working with, to be converted into CAMP. CAMP is just cyclic AMP, so cyclic adenine monophosphate instead of triphosphate. CAMP is really important because CAMP is going to activate a protein kinase. Kinases, and it's an A, so you know it's an enzyme, are just enzymes that phosphorylate things. So this active protein kinase is going to be able to phosphorylate your calcium channels in your sarcoplasmic reticulum and the channels in your plasma membrane to allow calcium to come inside our cells. Okay, now the third thing that affects stroke volume that we need to talk about is the afterload. And this is the pressure that the ventricles have to overcome in order to actually eject their blood to the systemic circulation or the pulmonary circulation. So we always have pressure coming back from our arterial blood that's going to push on our semilunar valves. That's the major pressure. If we're talking about coming from our aorta, the pressure back on the semilunar valve is around 80 millimeters per mercury. If we're talking about the pressure from our pulmonary trunk pushing back on our semilunar valve, that's about 10 milliliters per mercury. Hypertension also can increase afterload, and that's going to result in a higher end systolic volume as well as a reduced stroke volume. So what hypertension does is it basically reduces the ability of your ventricles to eject blood, and that's going to mean that you're going to have more blood stay in your ventricles after contraction or after ventricle systole, which means you're going to have a higher end systolic volume and ultimately a lower stroke volume. So that's why afterload or hypertension, either one of these are going to decrease. If we increase those, are going to decrease our stroke volume. So this is the unique thing that can affect stroke volume, in which it hurts it. Okay, now let's talk about heart rate. So we talked about everything that can affect stroke volume. That was preload, contractility, and afterload. Preload was the stretch. How much can we stretch our ventricle muscle cells to allow it to fill? So that's going to affect end diastolic volume because that's the max volume of blood in your ventricles before they contract. We also talked about contractility, and that was the ability or the strength of your muscle cells when they do contract. So that's going to affect our end systolic volume, so the volume left in our ventricles after they contract. Both of those, if we increase preload or we increase contractility, we've increased the amount of blood that we pumped out of the ventricle, so ultimately increase our stroke volume. Afterload is that pressure that the ventricles have to overcome before they can actually push the blood out into your aorta or your pulmonary trunk. The higher that pressure is that's pushing back on the ventricles, the lower the stroke volume. So hypertension is a disease that can increase your afterload, which is ultimately going to decrease your stroke volume because it increases your end systolic volume, or the amount of blood remaining after contraction. Okay, so now we're looking at the other component of cardiac output, and that's your heart rate. So a couple things can regulate or change our heart rate, which will ultimately change our cardiac output. And those are the two divisions of our autonomic nervous system, some chemicals, and some other factors that we're going to talk about. So things that can increase our heart rate are called positive chronotropic factors. So if you think about chrono means time, you'll realize that that's going to be your heart rate. We talked about positive inotropic agents. Ino means muscle, so those are ones that are going to affect your muscle cells. This is going to affect heart rate. Negative chronotropic factors are going to decrease your heart rate. Okay, so a big factor in increasing our heart rate and ultimately our cardiac output is going to be our sympathetic nervous system and a stimulation. So this can be emotional, so if we're scared or stressed, so your heart rate is probably really, really high now because you're stressed listening to all this material, or something like a physical stressor like exercise. And again, I mentioned previously that we're working with the neurotransmitter norepinephrine that's released by the postganglionic neuron in the sympathetic nervous system, and that's going to bind specifically the beta 1 that's in your heart adrenergic receptor. And what is that going to do when it binds? It's going to cause your pacemaker. Remember, your pacemaker is your SA node. So it's going to cause your SA node to fire more rapidly, which is ultimately going to increase your heart rate. Your end diastolic volume is going to be decreased because now we're increasing our heart rate, which means our ventricles have less time to fill. If our ventricles have less time to fill, we're not going to get as much max volume in there before they contract. So if we increase our heart rate, we're going to decrease our end diastolic volume, how much blood is in there before we actually contract them. But we are going to increase our contractility. So we're going to decrease our end systolic volume because we're able to increase the contractility, which means we can push more blood out of our ventricles into our aorta and our pulmonary trunk, and this is going to increase the volume of ejected blood. So if we went back and looked at stroke volume is equal to end diastolic volume minus end systolic volume, you would think that if we decreased our end diastolic volume, we would decrease our stroke volume. However, because we also decreased our end systolic volume, we really had no change at all on any of this, okay, because they both kind of even out. So that's what that's saying here. So because we decreased both our end diastolic volume and our end systolic volume, we really don't change our stroke volume at all. So let's keep going. Again, when we talk about the sympathetic nervous system, we're more worried about heart rate than stroke volume. So everything that our parasympathetic nervous system did, like speeding up our heart rate, is going to be the opposite in our parasympathetic nervous system. So it's going to oppose the effect. So The parasympathetic nervous system, if you remember, both its preganglionic and its postganglionic neuron release acetylcholine. So that's its neurotransmitter. And that's going to cause the pacemaker cells, so those cells that are in your SA node, AV node, and that conduction system to hyperpolarize. And that's going to allow your potassium channels to open up. And as potassium leaves, it's going to cause hyperpolarization of the cell. This is going to slow your heart rate. So we would expect the parasympathetic nervous system to do this, while the sympathetic nervous system is going to increase it. And again, it doesn't really have any effect on the contractility of your heart muscle cells at all. Let me see if there's anything else missing. Okay, so let's talk a little bit about vagal tone. Both divisions of your autonomic nervous system, so both your sympathetic and your sympathetic, are constantly sending impulses to your pacemaker cells and your SA node, but there is a dominant influence, and that is inhibitory. And why is it inhibitory? It's because of vagal tone. We talked a little bit about this in AMP1, and now we're coming back to it. So the parasympathetic nervous system is actually the dominant influence on the heart. So it's going to keep a decreased rate of about 25 beats per minute. If we were to cut our vagal nerve, it would increase our heart rate to about 100 beats per minute. However, if we're scared or stressed or frightened or being mugged or something like that, our sympathetic system can take over and can be activated to go in and increase our heart rate. We have something called the atrial Bainbridge reflex. This is just an autonomic sympathetic reflex that's initiated by increased venous return. If we have increased venous return, we're going to increase the amount that we fill our atria, so it's going to lead to increased atrial filling. What happens is, as we increase our filling, we're going to stretch our atrial walls. If we stretch our atrial walls, we can increase the volume in which they can hold. When we increase the volume in our atria, this is going to stimulate our SA node, because remember, our SA node resides in our right atrium. So because it's going to stimulate our SA node to depolarize and fire, it's going to cause contraction, which is going to cause an increase in heart rate. It's also going to stimulate atrial stretch receptors that don't stimulate the SA node, but that activate sympathetic reflexes to also increase our heart rate. So here's a good little flow chart. When you use this little flow chart to see the effect on cardiac output, I would start at the bottom. So we're looking at things that increase cardiac output. Anything that's opposite of these arrows or the direction shown here would decrease the cardiac output. So again, if we're trying to increase cardiac output, we can do so by increasing our heart rate or increasing our stroke volume. We'll start with heart rate because it's easier. If we increase our heart rate, how can we increase our heart rate? Increase our sympathetic activity. So the amount of norepinephrine landing on our beta-1 adrenergic receptors. And we want to also decrease our parasympathetic activity, because remember, that's our inhibitory tone on our muscle. So how do we change these two things, both divisions of our autonomic nervous system? We can change them in response to, if, like I said, if we're exercising, stressed out or anxious, or have a decreased blood pressure. So for example, decreased blood pressure would be if we got hurt and had some blood loss, that would contribute to a decreased blood pressure that would cause all of this to happen to increase our heart rate. The other factor that affects cardiac output is stroke volume. So if we want to increase our stroke volume, how do we do that? We can increase our end diastolic volume. So again, that's the max amount of blood in your ventricle before we contract. So if we have a huge amount of blood in our ventricles before we contract, we're going to increase the amount of blood pumped out by each ventricle in a minute, which is our stroke volume. How do we increase the amount of blood in our ventricle at rest or during diastole? Well, we increase the amount of blood going to it. And how do we do that? We increase our venous return. How do we make more blood go to our heart and increase our venous return? We can exercise, increase our sympathetic activity. We can increase our skeletal muscle activity, anything like that. We can also increase the amount of end diastolic volume by increasing the amount of time we allow the ventricles to fill. So if we increase the amount of time that we allow them to fill, they can fill with a larger amount, increasing our end diastolic volume. How do we get that? We lower our heart rate. So the less beats we have, the less contractions we have, the more time we have for them to fill between each beat. If we're talking about lowering our end systolic volume, that's going to increase our stroke volume, so the amount of blood left over in each ventricle after each contraction. How do we do that? We increase our contractility. So the stronger our heart muscle is, the more it can contract and push out. The more blood it can push out, the less that's left over at the end of systole. What can increase our contractility? Calcium. That's huge. The more calcium we have, the more cross-bridge formation we can have. Chemicals like thyroxine, epinephrine, we already talked about its effect on that. So kind of look at this flow chart and make sure that you understand the effects, and then we'll do a worksheet on it as well in class. So these are just some examples. So the hormones, we already talked about these. They can regulate heart rate. Ion concentrations, the big ones here are calcium and potassium. Age, so the younger you are, the faster your heart rate. The older you are, typically your heart rate declines, or the more athletic you are. Gender, so females typically have a faster heart rate than males. Exercise, we already talked about. That's going to stimulate your sympathetic nervous system, which ultimately increases your heart rate. However, if you exercise a lot, you're naturally going to have a lower resting heart rate there. Temperature pretty much increases everything. Metabolic reactions in your body. So we would expect that body temperature would increase our heart rate as well. And then these are just things that you need to go in and kind of learn what they mean, the different diseases, and that's the end of this chapter.